Sunshine, she's here. You can take a break. I'm a hot air balloon that could go to space with the air, like I don't care, baby. By the way, because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like that's what you want to do. Here come bad news, talking this and that. Well, give me all you got and don't hold it back. Well, I should probably warn you, I'll be just fine. No offense to you, don't waste your time. Here's why. Because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like that's what you want to do. Hey, go. Bring me down, can't none bring me down. Your love is too high to bring me down. Can't none bring me down. I said, bring me down, can't none bring me down. Your love is too high to bring me down. Can't none bring me down. I said, because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like that's what you want to do. Because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like that's what you want to do. Hey, go. Bring me down, can't none bring me down. Your love is too high to bring me down. Can't none bring me down. I said, because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Hey, hey, hey. Clap along if you feel like that's what you want to do. Because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Hey, hey. Clap.
Good afternoon, everyone. Thank you very much for joining us. We're going to start in a couple of minutes. So if you could kindly settle down a little bit and try to finish up your meals, and then we'll start in a couple of minutes. So, good afternoon, everyone again. So, welcome to our PCC webinar. So, today we are very lucky to have all of you join us in person, as well as we have a group of doctors joining us via Zoom. So, we have both in person and virtual attendees. So, welcome to everyone. Thank you for taking your time off from your busy schedules to join us on this Saturday afternoon. We truly appreciate you making a time to be part of this PCC webinar. Okay, so before we start, just some ground rules. So for those of you who are joining us on Zoom, just please take note. Sign in with your names and MCR number. During the presentation, you will be muted, but please feel free to put in your questions into the Q&A box. At the end of the presentation, we will try to answer as many questions as possible. And the people who are joining us in person, please feel free to ask any questions that you have at the end of the session. Okay, so today we've got myself. I'm Dr. Tanuja. I'm a medical oncologist with Parkway Cancer Center, and as a medical oncologist, I specialize in general oncology as well as with subspecialty interests in the management of lung, genitourinary, breast cancers, and head and neck cancers. And my subspecialty training has also been in geriatric oncology, looking after elderly patients with cancer, because as you know, in most of our developed countries, we all have an aging population. And my co-speaker today is my very good friend, Dr. J. Lim, and he's a urologist with Panasia surgery. We go a long way back. So when I was training in National Cancer Center, Jay was the urologist in SGH, and so we used to work very, very closely together. And I can assure you that he's one of the best urologists that I know, because whenever I refer my cases to him, he always treats the patients very well and does an excellent job. So Jay completed his urology surgical training and is interested in stone-related research. He underwent a fellowship training in Australia in robotic surgery, and Dr. J specializes in kidney conditions such as acute renal colic, horseshoe kidney, single kidney, pregnancy, and stone-related ones. He is trained in a full spectrum approach for addressing large and small renal stones, including endoscopic, laparoscopic, and ultrasound-based supine percutaneous techniques for large stones. Yeah, so today we will be talking in particular about testicular cancers and germ cell cancers of the testicular cancers. And we'll start off with Dr. J, and then thereafter I will give the medical oncology input for testicular cancers. And if you have any questions, we'll be happy to take them. So without further ado, I'll pass on to J.
Okay, thank you very much. So Tanuja and I go a long way back, but still I must thank her for a very nice introduction. So pretty much after what we've said, thank you very much for spending your busy schedule with us today. I know me and her talk standing between you and having the weekend ahead, so we will try to make this as relatively short and as bearable as I can. So without further ado, I'm just going to go straight into today's topic, which is basically what we would call it, I got that for the last on my testis. Now, as a urologist, this falls under the purview of my care. And testicular cancer is actually one of the rarer cancers that they generally only affect a very young population. This is very different from the other genitourinary cancers, or in fact, any other cancers that we all know. This particular one is only affecting young gentlemen around the age of 18 all the way to 35 or maybe even 40. So it is actually not so common in the overall scheme of things. So I mean, only accounts for around 1% of all solid organ cancers in male. But despite that, in America, the numbers are standing around 10,000 cases a year. The incidents are increasing. We don't really know why. There seems to be no strong epidemiological evidence suggesting why. It's from the food we eat and things we do. But certainly for sure, the good thing about this cancer, luckily for most of us here, is that they don't affect the Asian population that much. The Caucasians have the backdraw here, the Australians and the Europeans have a high incidence of this condition compared to the rest of the past. Having said that, this cancer is unique in that it has come a long way since the 60s all the way now to the management approach for testicular cancer. From a survival rate of about 63, 63, is basically now improved to anything around the age of more than 95% survival rate across all stages. Unfortunately, still globally, still a fair number of patients that comes to this disease at 9,000 deaths globally, and a lot of it is probably because they don't have access to high-quality healthcare in a lot of disciplines. For Singapore, in particular, the local data is actually that came from Singapore Society. So over the years, around 30 million, 3-decade period, Singapore is this around 264 cases online, which is a good thing for us. When you have this condition, the goal here, no matter what stage you present with, the goal is curative intent. So as long as they don't come with aggressive disease or too late, generally anybody that comes through with suspicion of testicular cancer, there's a very high likelihood that we should be able to cure this condition. So let's go straight into the testis itself, and let's go with just to refresh everybody's memory in terms of anatomy. The male reproductive system, apart from the testis itself, also consists of the epididymis, the vas deferens, and the ejaculatory ducts. It's an inline structure with the urethra and the prostate, and the penis in the midline itself. Because of this condition, it's very likely that if your patients present to you and you don't think about it, you probably will not diagnose it. There's a lot of stigma involved, particularly if they're at the prime of their age. Nobody likes to go to the doctor and tell them, I got a problem with my man. So if you don't think about this condition, unfortunately, you will be missing. The testing itself has a variety of stages. The sizes as well, there's no one size fits all. There is a product that kilometer that some of you might have in your practice that gives a good estimate of the volume of testis, but regardless, you should balance left and right. Even if you don't really know what exactly the size, that's always tricky. It is important in the sense that not just for spermatozoa production and storage, it is essential for androgen, basically your testosterone production. Okay? And obviously, naturally, the left side is going to be lower than the right side due to the descent of the testis, which we go through. Testicular descent, as we may recall from anatomy, actually doesn't start in the scrotum. It actually comes intra-abdominally, and as it develops, a lot of time in vitro or when we are still developing embryo is actually in the abdomen. That's the stage whereby it develops, and then just before birth, it actually then transits down from the abdomen through the inguinal canal, which is the final spot in the scrotum. 3 phases of the descent. First is the initial phase, which is the enlargement intra-abdominally. A lot of us don't actually do it at that stage, because the first and second stage was essentially just going inside the tummy and goes through the inguinal, which is the second stage, and the final stage is where it actually reaches the scrotum just before birth. So just a fun fact, a lot of times the high incidence of torsion is actually at around birth time, because if there is a problem, it usually happens at the point of the third phase where you transit from the inguinal region over the scrotum. So many kids actually are born with dead testes. That's why some of you who does neonatology will know that checking for testes is one of the key components of a newborn baby examination. The majority of the cases of testicular cancers are germ cell. There are some of the rare ones, 95% of them are germ cells, and then there are some of those like the sex cord and the extraplacental type of cancers. But 95% of them are on germ cell basis. Within germ cell, about half of them are seminomas, with the rest basically non-seminomatous NSGCT or non-seminomatous germ cell tumor. It could be a mix because there's a few histological subtypes, and generally there is, depending on what kinds of presentation in terms of their serial markers and elevation, we can work out what are the various subtypes and what are the real components of the cancer that you have in there, where it's very dealing with the NSBCT. So really, there's a whole list in terms of the World Health Organization classification of testicular cancer, but the one that we're really interested would be a smaller total component of the one cell. So for NSGCT, so I'll say to you, it could be a mix of the subtype. You could have milk cell, milk sac type of the embryonal site, or you can have choriocarcinoma. Choriocarcinoma being one of the least common, but also the most aggressive of NSGCT. A lot of them do present late. As I explained, a lot of stigma involved, but when they come to you, 1/3 of your presenting patients will be young. You will never think first diagnosed with cancer, but they generally do present with non-testicular conditions, for example, from cough, dyspnea, neck lumps, CNS involvement in the whole thing. Okay, so if you don't think about it, sit like this. There are other presentations, like I mentioned, that we will go through a bit later. So just to look at some of the histological subtypes, I'm not going to bore every one of you here with the histological features. I myself am not an expert in them, but the various type of components that makes up the NSGCT could be the yolk sac type and embryonal type and choriocarcinoma type. For a lot of the cancers, the first initial treatment in intervention in terms of surgery will be lumpectomy. The only exception will be if you have a choriocarcinoma. In certain cases, they present emergent need from retroperitoneal bleeding. And only in these cases, we actually treat the bleeding first before we actually touch the testis. If not, for most other testicular cancer, a high portion of them is the surgical intervention as the first step. Okay. Let's look at some of the risk factors we have, just to do a quick rehash of what are the risk factors involved in developing this condition. I believe all of you will still remember that cryptorchidism is actually one of the well-known risk factors in that up to 10% of the testes can develop testicular cancer, which is why we actually look for it in the newborn. For those that have one missing, then we go through a lot to find out where it's. Okay, it could be stuck somewhere along the canal, or it could be stuck more high up into the in the abdomen itself. And we will do a lot of things that we try to basically bring it from the initial position back to the scrotum. And there are two main reasons for that. If you want to do it early enough, there's a good chance that you can place it in an orthotopic position. There's a good chance that the testis itself actually develop and catch up, and therefore develop sleep normally and can fulfill its function. It is only helpful if you do pre-note. The other reason, equally important, is that even if you actually do not have any catch-up, it is a position that it allows the patient itself to do a quick and simple self-examination. Because if you leave it inside the abdomen, it becomes cancer, there is no other way of figuring out, which is why if there is no way of bringing the testis from the abdomen down to the scrotum, we rather do a repeat. After all, you only need one physiological route to supply. Okay, that's one of the main reasons. If you have bilateral cryptorganism, then obviously twice the risk, and the numbers are quite convincing. 2 times, up to 3 times the relative odds ratio compared to normal populations if you have cryptorganism. If you have a history of a GCNNS, which is basically as inside the pre-cancerous space, it is also a very significant risk factor. And how we figure this part out is that when we look at the histological types, histological examples of people who actually develop testicular cancer, we found that neoplasm in situ is actually always surrounding the main focal cancer. So if anything else, it's kind of like a theme change. One part of the testis change, everything will change accordingly, which is why you probably have something like a testis preserving surgery, you kind of half just remove the division, we are dealing in the future. Similarly, it means that in one side if you have it, it's a good chance that the other side. So it's something that you need to know as well. And if you were to have neoplasm in situ, the progression rate is up to 50%. So it's not an insignificant number. Hyposphalia is one of those rare conditions that you also must remember. And the rationale is because of the dysgenesis in terms of evolution development of the male organs. There is some pathway this disorganization, degenesis, therefore leads to hypospadias as well. So, and it is the restriction is quite clear. If you have hypospadias, you're about twice more likely than the general population to develop testicular cancer. The position of which the neo-urethra is also important. The more proximal you are, the higher risk you have compared to someone who is just a bit off from the orthotopic position in terms of the answers. For family with Down syndrome, it's also something that we will see a lot in our practice. So you need to remember that if one of our patients have family members who are Down syndrome, particularly Down syndrome, as you know, it can be a bit hard to manage, but it is important that the parents of the family do a bit of regular examination just to make sure everything is well. Testicular microlithosis. This is something I believe all of you would have seen it once or twice in clinical practice, and there's been a controversy when it comes to talking about TM. It has always been taught in the books in medical school and same thing with me that it is associated with the higher risk of testicular cancer. In fact, the systematic review done by NCC looked on looking at 1,343 patients across the 3 reports. They found that if you have testicular microlithosis, you are 8 times more likely to develop testicular cancer. That's along with the risk factors that we talked about, like crypto and contralateral PCTs, history of testicular cancer. But the numbers don't add up. Why? The incidence of testicular microlithosis in the general population is around 2.4 to 5.6%. And even if you take a conservative estimate about 2%, then that's to say you should be having around 1,000 times more testicular cancer patients than BCC. And we know that that's not the case. So therefore, the numbers don't work both ways. Okay? And part of the reason as to why that may be the case is because we are having a lot of advanced instruments at our hands right now that can be a smaller TM compared to usual. So it's one of those things that hasn't been fully established in terms of the fact that it's not happening more from the CT and equals testicular cancer. Okay, but it is something that we see very, very commonly, and I do still occasionally get referred. And if there's any doubt, very happy to see them and we'll move to this as well. The signs and symptoms. 1/3 comes with metastatic signs. You can not just basically have painless testicular mass, which is the most common. And what we normally hear is that although it is painless testicular mass is the most common presentation, a lot of them will tell you it's only because they had a recent accident. The most common is having soccer game, they actually had a bit of accident, or they were riding a bike and fell down, strategy. Then they start getting aware of scrotal tenderness, they start feeling it during shower, and by the time they come to visit, yeah, I think there's something. That's generally the most common. So it's a lot of times people might actually come to you already delayed because they have no idea how long that mess is really there. Other common signs naturally can include pain, which is not common, around 10% only. Then you have gynecomastia, and gynecomastia presents about 5% of testicular cancer, and the rationale for that is because of the beta-HCG production in, for example, the trophoblastic cells or the colorectal type of cancer. So that's not really a sign because the beta-associated is a You can have neck masses, dyspnea, cough, anorexia, bloating, CNS, and lower lips are pretty much like every other major cancer. So you don't think about it, you need this. Differential diagnosis when it comes to that, generally probably classified into painful and not. If the guy comes to you with a pain in the testes, you're probably looking at abortion or epithelial bronchitis. Painless still, and it's diffuse when I think about lymphoma, and true enough, some of our people will always look at the scan and be like, it's good. It's actually one of those very different diagnoses. If it's non-tender and it's been there for quite some time and doesn't have any systemic manifestation, consider hydrocele or even stomatosis. The first step to diagnosing the testicular cancer is obviously examination, and this is as sensitive as doing a breast examination in ladies. You want the individual that's actually covered enough, warm the hands-on environment, and basically do a live examination. No matter what you do, the ladies I assure you, you will be concentrated, don't worry, it's okay, they will die. But we do want to have a full examination and make sure that you don't do a good job. My manual one basically starts from the normal side first. The things you're looking out for is the size, consistencies, and whether they are balanced or not. Alright, not everybody might be those wrong thinking, everybody's private religion. So we may not be very much. It's okay. As long as they look about the same, you're probably okay. And basically, if you have lower leg swellings, that's something that you want to check out at the same time because generally they are naked by that. After the exams, okay, the diagnostic pathway is actually quite straightforward. When you find a mess, and you're convinced there's a mess, we do our transport. And then on top of that, we do a single markers, which you will do. Okay. Then in between, you will do a staging scan. Once you confirm that there's a mass and then the serum markers will be elevated by 10, we want to do a CT scan. And from then on, usually you will pump it after the urology and first time out. That's essentially the good outcome. Okay. But I can tell you that once we have a confirmed diagnosis, or rather, if let's say the evidence, the staging has really been done for me by my time office, and usually the next step is we do a radical diagnosis. Basically, what we do for the majority of the time. The exception being the bleeding emergencies in certain subtypes. Those cases, they probably will be sent to the emergency department, not so much GPs, which is okay. And then depending on what's the staging and what's the histological subtype, the KIV will be the RBLD or will be sent for chemo, which the will cover it. So, like any other cancers, there is a TMN staging, and TMN stagings are easily available online. Again, there's no point in memorizing everything. I don't memorize it, there's no point because it's too many. Okay, but the unique thing about testicular cancer is that it does not just have TMN, it also has S, which is the serum markers. The three types of serum markers that we look out for is basically the alpha beta protein, beta HCG, and the LDH. These two types basically can tell you what are the subtypes of cancers that we're dealing with. Some of them will be elevated, some of them will not AFP, some of them beta HCG can be as high as about 10,000 times. And then from then on, you pretty much work out what kind of tumor. And then you then work out whether you need to have chemotherapy or you are already out of the LDH, on the other hand, is not so much as a marker, but it's a wonderful way to use it as a marker for a treatment response and basically as a prognostic effect, a prognostication effect. So there are many ways we classify that, but long and short story is S1 to S3, the 3-1 being a bit more prognosis because of the various high levels of serum markers that can occur. The IGCCCG stands for the International Cell Collaborative Group. Basically, also use the serial markers and come up with a prognostication chart, and they divide cancers into the good, intermediate, and the poor group, as you can see. With pure centimeters, they actually they're doing so well that there is essentially no patients in the poor group. Okay, because we basically have come very far in terms of coming out with treatment regimes that a lot of them actually die. Even for the non-segmental metastasis, because of the various subtypes and we have more of this and that, the survival, 5-year survival is around 45%, even at full prognosis group, and it can go as high as up to 90%. So across all stages, therefore, if the majority of them present in stage 1, the overall survivability is up to even higher than 95% of the last surveillance. So what do I do after I see the patient that you refer to me? The first step is always in-one appendectomy. In-one appendectomy being the key, but it's not a stroke appendectomy. The rationale for that is because that the scrotum itself has a different lymphatic grading compared to the pathway of the cell, which is from the abdominal through the inguinal canal and into the scrotum. What does it mean? So it means that if you were to attempt to do a appendectomy via the scrotum, which is a preferred approach for most other testicular issue, you run the risk of seeding. And if you run the risk of seeding, then you're dealing with lymphatic spread across 2 different zones. And that makes things very, very much harder. Tanuja will not be very much. So what we do is actually we use a one approach, and actually what from then on we deliver the testis, even though it's a fair bit away, we have ways to basically do it, and we deliver double prime time before we even do any more further dissection, so as to not disseminate cancer. Okay, once we are happy, we basically chop away, and we isolate the vessels and we chop away everything else, and we then do a rolling suture. Why rolling suture? Because we had to leave it long. And we use a non-zero suture, and we cut everything back into the inguinal canal and finish it up like what you do for a fungi. The rationale for that is because if in case you need to do RPMD, goes through top-down approach, you can actually identify the cord through the rolling stage and then reset everything. So it's one of the few things, few times whereby we leave a long tail behind, especially the new trainees, and we actually go through them, but most of the time we actually go back from the inside. Also remember when you do appendectomy, there's a chance on the contralateral side that something else might be going as well. Okay, this is very important because we're talking about fertility preservation as well. So after the radical appendectomy, what do we do? A lot of the times, that's all we need to do. Okay, and especially if you find them early, and you detect them early, that's essentially what is the whole treatment. And you go around surveying them through the combination of serial markers and imaging. And if you do it for a lot of time, about 1/3 of the time, these are usually due to micrometastases that were not clearly evident in the initial staging, and they are usually spread to the retroperitoneal lymph node, therefore leading to the fact that we need to do additional treatment like RPMD and chemotherapy. And then once we're done, basically we go back to the circle, we keep going and doing expected surveillance until we are happy that is cured. So RPMD, we come to say a few times about this word. So it stands for retroperitoneal lymph node dissection. It is basically the standard surgical approach for NSGCT in the primary and post-chemotherapy setting. Having said that, it's not actually done very, very commonly. In Singapore, we conduct less than 20 cases in the country, less than 10. It does have its benefits. It's great because once you strip off the entire lymph node group in the posterior peritoneum, retroperitoneum, you can have a very, very accurate staging. And it's at the same time therapeutic, especially if it's post-chemotherapy that's residual mass. Some of the subtypes are not resistant to chemo and radiotherapy. You basically, it's a therapeutic process where you can cure cancer just by removing it. And essentially, if you have an NHGCT that has a posterior lymph node involvement, it cures it in 93% to 93 to 95% of the time as well. If it doesn't work, then we send it to Tanuja comes in and basically helps me with the chemotherapy as well. It can be done through a variety of approaches. The most common is actually a large line incision. It's one of those big surgery that's still is done through the old school way, because that's no other way to do it. You will be needing to go through the entire retroperitoneum, means that the large vessels needs to be, all the lymph nodes around the large vessels need to be removed clearly. You need to actually just roll the IVC to one side, remove all the tissue. At the end of the surgery, you see three large vessels that's thinly stripped of any additional lymphoid tissues, and that's how you need to do the surgery. So it has a bit of morbidity involved in that. First and foremost would be active ejaculation. Ejaculation is almost always effective. There are some modified nerve sparing techniques that can be done, but they are only for selected patients and not necessarily for anything else. And if you would do the nerve sparing, you can actually preserve fair bit, but it's only for certain patients, not for everybody. And why we do a retroperitoneal lymph dissection? Because again, it has something to do with the descent and the path it takes. If you have testicular cancer, the spread is usually along where they started off in life and where they eventually end. So essentially going down from the abdomen, just below the kidney, all the way down to strip everything else. And it's actually very predictable. Therefore, we can actually use a template to do this surgery. And depending on how bad your condition is, you can actually do a unilateral or bilateral, but essentially within anything within this black color box for bilateral RPRND, you need to strip off all the lymphoid tissues. And because of that, fabulous, 18% is not a small number. Infection, ideas, lymphocyte is very common. You can get a pulmonary embolism, and of course, you can injure the vessels as well. Therefore, it is something that we only do more regularly when we have to. Okay. Because of the age group of our patients, especially in the prime of their life, we need to consider fertility consideration, especially if they are married. Some of the options available includes sperm banking and oral consideration, and it needs to be done before you subject the patient to any RPRND or chemotherapy. Of note, you must understand that the person who is actually predisposed to have testicular cancer probably has some function, there's something wrong with their spermatogenesis function as well. So this group of patients, 50% of the time, you may not be getting any viable sperm compatible population. All the while, you need to talk to the kids about this. You need to get a reproductive specialist involved, and if you will do a pedectomy, consider having an implant. Just about this month, I've actually got a random Facebook message from a guy in South Africa who has tested with 12 years ago and asking, hey, are there any implants? Okay. Anyways, we're both going to come head up to chemotherapy and go ahead into Dr. Tanuja. But just before that, I want to round up what I've already talked about. It is a very curable condition. The key to that is having a weaknesses. Okay. And if you don't think about it, you may not be looking at it. You need to think about it, otherwise you forget it. Fertility preservation is very important to their age group populations, and there are many multiple treatments. And with that, go ahead and over to Tanuja, who's going to talk about the chemotherapy possibilities. Thank you.
Thanks very much, Jay, for the very insightful presentation. So I take over talking from Dr. Jay. So I'm going to talk about the medical oncologist perspective and where we come in. Right, so this is the outline talk. I hope to be able to talk to you about some case-based scenarios, because that's the best way to illustrate patients' journey. So I know this diagnostic outcome of parts. I'll go through this part very quickly. So as Dr. J already covered this part, the main thing is, I think for the GCs, based on my experience, sometimes it's difficult to identify a testicular mass. Sometimes people come in with testicular swelling, and as GPs, we don't see this so often. It's difficult to tell, is this normal or is this not? And I think when you're in doubt, please I get an opinion from a specialist, or get at least a testicular ultrasound, because whenever any testicular mass can potentially be testicular cancer, and if we detect it early, the chances of cure is much higher, and outcomes for the patients are also much improved when we detect these cancers early, as you will see. And of course, once the cancer is diagnosed, as Jay mentioned, we'll get serum tumor markers, and most of the time, as part of the biopsy, we will get people go for radical and one orchidectomy. Unlike the breast cancers where someone has a breast breast mass, you will go for a biopsy. This we do not do biopsies in testicular cancers because of the risk of seeding. Right, so we go up or upfront for a radical inguinal lumpectomy. Right, so whenever we really got the diagnosis of cancer, as an oncologist, we always do staging. We want to see whether the cancer has spread to any other part of the body. The most important is the CT, chest, abdomen, and pelvis. And we need to do an MRI grade only in selected cases. For example, the patient has CNS symptoms, or for example, we see a histology of cholangiocarcinoma or very high beta HCG levels. The common question I usually get from the GPs is, why need to get a PET scan for these patients? The short answer is no. Right, a PET scan is not included in the initial management of testicular cancer, but we can sometimes consider a PET scan down the road as a post-treatment evaluation for the seminomas. Right, so this example of one of my patients, a huge retroperitoneal mass that you can see in the CT abdomen pelvis, and this is CT scan showing lung mass. So when it comes to the staging, as Dr. J said, is a TNM staging. The T stage tells you whether there's vascular invasion in the film part or the schematic part or the scrotum. The lymph nodes tells you the size of the lymph node mass, and whether there's any metastatic disease. And the thing that's most special about staging is there's the S staging. This is basically the value of the tumor markers after orchidectomy. So whenever you see a patient with suspected testicular cancer, we always do the tumor markers before surgery, and we follow up with the tumor markers after surgery. And we expect the tumor markers to normalize based on their half-life. So if the patient has only a testicular mass, we remove the testicular mass, but the serum tumor markers are high, then they fall into one of these S categories. Right? I hope this is clear. So there's a possibility that you've done the scan, the only thing you find is a testicular mass, you remove the testicular mass and get the serum tumor markers elevated. So which means that there is still some cancer in the body and potentially they may need further treatment. As you can see, stage 1 testicular cancers are basically just a tumor in the testis, right? There's no lymph node metastasis, there's no metastatic spread to any of the distant organs. Stage 2 is if there's any presence of lymph node metastatic disease, and stage 3 is if there's any distant metastatic disease, either to the lungs, to the liver, to the non-regional lymph nodes. It is very interesting to note that in testicular cancer, there is no stage 4. Right? Even when patients have metastatic disease, they can be cured. Right? So as mentioned for the seminoma, 80% of them present at stage 1, meaning all they have is a testicular mass. And once you go for orchidectomy, they can actually cure. For the non-seminoma, 60% present in stage 1, 20% in stage 2, and another 20% in stage 3. Right, so how do we treat? So Dr. J does the orchidectomy, and then these patients will then come and see me. Right, so the question is, if you've already removed the testicular tumor, why do you need to see an oncologist? A lot of the patients also ask the same thing. Basically, although we have removed the testicular tumor, our aim is to prevent a recurrence, right? Adjuvant treatment. Adjuvant treatment has become very common now since Kate Reloaded, right, for the preventative chemotherapy. So that's exactly what it is. So for patients with stage 1 seminoma, the options are either they can go under active surveillance, that means they don't need any further treatment, but they follow up with us very closely so that we can detect a recurrence early. And if a recurrence is detected, then we can treat it at the point of recurrence. Right? Even if cancer recurs, they are still the chances of cure are still very high. The other option is adjuvant chemotherapy with one cycle of carboplatin. We look at the risk factors for the orchidectomy specimen. If the tumor is more than 4 cm or there's retrotestis involvement, then potentially we will offer patients one cycle of adjuvant chemotherapy. The other option is radiotherapy. This is not a very popular option because chemotherapy is a much easier option. It's just one cycle of chemotherapy one day compared to radiation where they have to come in for about 20 to 30 fractions, which means they come in 20 to 30 times when chemotherapy is just once. Right? So is there any difference in terms of efficacy between radiotherapy and chemotherapy? No, not in terms of efficacy. There's no difference in relapse-free survival. But with chemotherapy, it decreases the risk of contralateral testicular recurrence with chemotherapy. right? So if you have a patient with a stage 1 seminoma who chooses to go for active surveillance, we must tell the patient that they need to be followed up very closely, right? In the first year post-operatively, they need CT scan at 3, 6, and 12 months. But if they have gone for adjuvant treatment, then they only need a CT scan annually. So if you've got a very busy young banker who needs to travel all the time, never in Singapore, then surveillance may not be such a good option because they potentially miss out getting a recurrence. Right. So if you look at this, for whichever option you choose, so if the patient chooses the active surveillance option, the chance of relapse is 15%. If they go for radiation or chemotherapy, chance of relapse is not 100% cure, there's a 4 to 5% chance of relapse. But no matter which option you choose, active surveillance, radiation, or carboplatin, if the chance of cure rate is more than 99%. Okay, so meaning that if I choose active surveillance and cancer comes back, I still can potentially be cured. The only difference is if I get adjuvant chemotherapy, is one cycle of carboplatin. But if the cancer recurs, then I need a multi-regimen chemotherapy for 3 to 5 cycles. Right. So next we switch gears to talk about the non-seminomas. So for stage 1 non-seminomas, right, basically a good proportion of them are cured by the orchidectomy alone. So we look again at risk factors. For the non-seminomas, risk factors and things like lymphovascular invasion, presence of embryonal carcinoma in the histology, or tumor stage of T3 or T4. If you're low risk, you have no risk factors. High risk if you have one or more. Again, what are the treatment options for the stage 1 non-seminomas is active surveillance again. This time there's no radiotherapy, there's the option of RPLND, which is retroperitoneal lymph node dissection, which is what Dr. K spoke about, or chemotherapy with a multi-drug regimen, BEP, is not carboplatin. Right, so this is BEP, is basically 3 drugs, bleomycin, etoposide, cisplatin. They of course come with acute toxicities of chemotherapy. There's nausea, there's vomiting, there's risk of neutropenic sepsis, but it's just one cycle of chemotherapy. Okay, retroperitoneal lymph node dissection is mentioned by Dr. J. It is something that we don't offer to the patients because we need to be a high volume center to be able to do this. So in Singapore, no one gets retroperitoneal lymph node dissection as part of adjuvant treatment, only at recurrence. Right, the other option is of course active surveillance, and as again you look, if you have active surveillance, you need very regular CT scan compared to patients who have had adjuvant treatment. Yeah, so similarly, if you look at the chance of relapse is 10 to 15%. If you go for chemotherapy, 3 to 5% for active surveillance, depending on your risk, your relapse rate. These are your relapse rates, but again, overall cure rates is still very high for the non-seminomas. Yeah, now we switch gears, we talk about the advanced disease. So for example, advanced disease, that means the patient already comes in not just with a testicular mass, there's already spread of the disease to the lymph nodes, to the lungs, to any other part of the body. And the poster boy for this disease is actually Lance Armstrong. So if you know, he presented with stage 3 non-seminomatous germ cell tumor. He had brain mets. Right, he was cured with chemotherapy, and he went on thereafter doing 7 Tour de France titles. So this is a very curable cancer, even if it's metastatic disease. And this is the treatment paradigm. Even if they have metastatic disease, we usually still refer the patients to go for a orchidectomy to get histological diagnosis. Thereafter, they will need chemotherapy. And if there's any residual masses, we'll talk about what needs to be done, and then eventually they will need follow-up. Right, so as what Jay said, for patients with advanced disease, we risk stratify them into good risk, intermediate risk, or poor risk. This is based on their tumor markers, the site of metastatic disease. So depending on whether you are a non-seminoma or a seminoma, your treatment varies. So if you are in the good risk, you need 3 cycles of chemotherapy. If you're intermediate or poor risk, you basically need 4 cycles of chemotherapy. Right, and let's say after you finish chemotherapy, we will do a scan. So that's when a PET scan will come in. So if you have a seminoma, right, and if let's say you do a CT scan, there's a residual disease, that means there's a lymph node mass or 10 that is in the abdomen, then if it's more than 3 cm, you want to do a PET scan. If the PET scan shows that this is FDG avid, is bright, then you want to go and remove it. If it's not avid, then you can say, okay, maybe I'll watch and repeat the scan again. Right, if it's less than 3 cm, you can potentially watch these tumors. For the non-seminomas, if they have any residual masses more than 1 cm, generally we say go for surgery because in the either be a teratoma, which we should remove because teratoma can turn cancerous, or they can still have wider germ cell tumor inside that we should remove the chemotherapy then kill, right? So, but what happens whether even for the advanced disease, cancer can, even with advanced disease or even the localized disease treatment, cancer can relapse even in such a cancer with very good prognosis. Most of the relapses occur in the first 2 years. So whenever you have these patients, watch them very closely, especially during the first 2 years. So the follow-ups are every 3 to 4 months in the first 2 years, right? So that any relapses, you want to pick them out early. Most of the relapses are detected due to symptoms, and less than 5% of relapses occur in third year or later. If you have a later relapse, the prognosis is worse, right? Even in the cancer relapse, it is not, some of these cases there's a 50% chance of cure. So we can either go for salvage chemotherapy, or there's an option of give high dose chemotherapy followed by stem cell transplant. This is an ongoing phase 3 study looking at patients with relapsed disease. Should we give salvage chemotherapy or upfront transplant? Right? This study is still ongoing. We don't know the results of this study, but this will help and tell us what should we do. But most of the time, we give them salvage chemotherapy. If that fails, then we go on to transplant, because transplant is not something that is simple. There's high risk of morbidity and mortality, right? And as mentioned, a lot of these patients are young men. They all go on to live very long lives thereafter. But because we give chemotherapy and radiotherapy, they go for surgery, survival. There's some long-term toxicities that these are some patients that may come to see you as well as GPs, right? So we see them, they tell you, oh, I've had testicular cancer before, I've had chemotherapy before. So these are certain things that you may want to look out for. So some patients may have rheumatoid pneumonitis, which is a result of the chemotherapy. This is more of a acute toxicity. This happens during the time of chemotherapy. It doesn't happen 10 to 15 years later. But usually for bleomycin pneumonitis is something we oncologists look after, and something that we are very, very, very careful about. So patients can come in presenting with cough, fever, difficulty breathing, right? So if, for example, someone is on chemotherapy and comes to your GP clinic and tells you that I'm on bleomycin, please, and they tell you that I cough or fever or difficulty breathing, first thing you do is please call the oncologist, right? Or we don't just send them back saying this is a URTI. This is potentially bleomycin pneumonitis, and patients can die from bleomycin pneumonitis. This is serious. Okay, so always watch out for it. The treatment for bleomycin pneumonitis is that the bleomycin will discontinue and we start steroids for this patient. So most important, if you happen to pick up some of these patients, call the oncologist treating the patient immediately. Most of them, I think everybody will be more than willing to take your call, because we give chemotherapy, infertility is an issue, as Jay rightly mentioned. So before we start chemotherapy, we send them for all sperm banking, so that if they want, because as I mentioned, some of the younger patient that I've seen as adult oncologist is a 15-year-old boy. Right, so these are going to be men who are going to grow up to have children and families. We want to give them an option now. Because we give chemotherapy, sometimes radiotherapy, these are certain cardiovascular disease that may become an issue. These men will grow up to be in your follow-up, right? They will have higher risk of hypertension, high cholesterol, chronic arteriovascular disease. So the recommendation is screening for hypertension every 2 years in the individuals above the age of 20, and checking the lipid profile every 5 years, even for the young men, because they are increased risk of cardiovascular disease. And also because of some of the chemotherapy they are given, their risk of secondary malignancy. The chance of secondary malignancy, it is low. It is generally, we usually quote generally rate is less than 1%, but this is something to remember, right? So because these men, some of these men are so young, we give them chemotherapy at the age of 18, 19, right? So, and when they live throughout them to 60, 70, they're at risk of a secondary malignancy. So just be careful when you see these young men. Some of the chemotherapy that we give can cause neuropathy. They complain of numbness of the hands, but usually it's very rarely we see very bad cases nowadays. But if we do, we send them to the rehab conditions early, right? And so I want to share with you some of my case, some of the case scenarios I have. So this is one of my patient. He's a 27-year-old Eurasian male. He was studying in Singapore in a private university, no past medical history of note. And what happened was he was crossing the road near Great World City. This was the time when I was working at NCC. He had a simple episode. Someone called the ambulance, and he was brought into the ED. And when he was in the ED, they found that he had a huge saddle embolus, as you can see here. Right, it's a pulmonary embolism, huge pulmonary embolism that basically caused him to collapse and had a right heart strain. So as they were working up for this pulmonary embolism, basically you can see there's a huge testicular mass, right? And this is a 27-year-old boy that speaks very, very well. And then I said, so I asked him, you got a 10 cm testicular mass, why do you give it that? So he said, I went to Google, and Google said it was a hydrocele. So you didn't have to do anything. So he just left this, right? So you can see here, this is real, right? And so he was admitted to the medical ICA because of pulmonary embolism. He needed IV heparin, he needed thrombectomy to be done. And part of his workup, he had an ultrasound scrotum, and the CT scan actually showed large retroperitoneal lymph nodes as well as disease that is spread to the lungs. Right, you can see this is a large retroperitoneal lymph node. There's about 10.6 cm that was compressing on his IBC, and this was his serum tumor markers. So these are really sky high. Men should never have a beta density high, right? Beta density is not prevalent with men. So another thing is very interesting about germ cell tumors is that these germ cell tumors is one of the only cancers that we can treat without a biopsy. Right, so if you see a man that has very high tumor markers, right, you can potentially start your chemotherapy without a biopsy. Right, so this man couldn't get go for a biopsy because he was on IV heparin, he was in the ICA, he was in crisis. They said, so we sat down, tumor board decided we're going to give him 4 cycles of BEP. And he was in crisis. There's no talk about sperm banking and things like that. You need to start treatment ASAP. So that's why I tell you it's very important that you see these patients early. But once we started treatment, you can see that this tumor mass shrank very nicely, 10.5 cm to 8.7 cm. And you can see this because he didn't have an upfront appendectomy for this man, because he was on heparin and all that, and nobody wants to touch him, right? So this is his testicular mass with the chemotherapy. You can see the testicular mass shrunk very nicely. His tumor markers came down very, very nicely. After chemotherapy, he was then sent for the inguinal appendectomy. But then, what happened is after cycle 4, he started coming complaining of cost, right? And this is his CT scan, right? And you can see this is basically pneumonitis from the bleomycin. So his cancer is doing very well, but he had this pneumonitis. But thankfully, we caught him early. He had a bronchoscopy to rule out an infection. He was started on high-dose steroids, and this is his CT scan. He's obviously one of the lucky ones whose bleomycin pneumonitis resolved, because there are people who die from bleomycin pneumonitis. Yeah. Okay, so this is my case 2 scenario. This is the scenario of extragonadal germ cell tumor. This is a 31-year-old Malaysian gentleman who has medical history of note. He works as a legal mechanic in Singapore. Right, so he presented with progressively worsening SOP, and you can see that there was chest tightness. He's only 31 years old. He's obviously quite a fit man, but he was losing weight, only able to walk for a few steps, and he waited until he was in crisis. Then he decided to come in, and when he first came in, he was unable to lie flat. His SpO2 was 4 liters, 96% on 4 liters, and you can see this is the strength X-ray. Doesn't take even your year 1 medical student will tell you that something is wrong with this X-ray. But basically, this was the CT scan. He had a huge thoracic mass, right? You can see 16.1 cm in the chest that's compressing in the right atrium and the superior vena cava. And then you can see the severe narrowing of the right main bronchus and the pericardial effusion as well. Right, 31-year-old man, and this one, his serum tumor markers were sky high. see AFP, beta HCG, and LDH. So in this case, you don't need to do a biopsy for this guy. You just need to start systemic treatment for him. But unfortunately for him, he was a Malaysian in Singapore. He couldn't afford treatment, and he said he AOR discharged and went over to Malaysia. And so this again brings up the scenario of an extra malignant germ cell tumor. So germ cell tumors can not only occur in the testes, they can occur everywhere else in the peritoneum and in the previous sinus as well. Right? This is the last case I have. It's a 54-year-old Chinese man. So this is he's in the older age range of the usual testicular cancers, and you see most of them are 20, 30, 80, 90, right? So he's an IT consultant, non-smoker, he's married, no kids. He was first diagnosed with the stage 1 seminoma 3 years ago. He had a appendectomy. He chose active surveillance. He didn't have radiotherapy, he didn't have chemotherapy, but he presented increasing abdominal discomfort for a period of 6 months. And as part of his routine CT surveillance, he picked up. You can see that this was picked up. There was an enlarged lymph node in the upper left upper tracheal region, and you can see this is a big mass here, 9.4 cm in the retroperitoneal region, right? And you can see that this was baseline. His beta HCG was low, and it had gone up to 76.8. His LDH had gone up. We did a cervical lymph node biopsy, features consistent with the recurrent seminoma. Now that the seminoma has recurred, we had to give him 3 cycles of BEP. It's no longer the 1 cycle of carboplatin that we spoke about. But you can see that even though this cancer has recurred, just after 3 cycles of BEP, you can see that the tumor has shrunk considerably, but there's a residual soft tissue mass. There's about 2 cm, not 3 cm. So I opted to observe it, and thereafter it resolved. Yeah. I think so. And you can see the lymph nodes. Initially, this was there, and it has resolved already. Yeah, so that's the end of my presentation. But I want to tell you, I think the main takeaway from this is testicular germ cell tumors are very curable cancer. They occur in the young men. So please, if you're a GP seeing this man, if you see a testicular mass, don't just say that this will be aggressive. Minimally, at least get a testicular ultrasound. If you're not sure, please send to one of us. We'll be happy to review this. And if you pick it out early, you can spare them lots of toxicity and long-term and lots of treatment, right? So basically, the last thing to take note of is testicular cancers are very curable. That's all I have. And also to end off, to tell you that April is actually Testicular Cancer Awareness Month, so we are very happy to be doing this in April. And with that, I would be happy to take any questions that you have. Thank you very much.
Life events, I'm sure is right.
Yes, that's right.
So he actually suffered cancer before once, sadly,
Yes.
But he was actually illegal. Yes. So
Is that a risk factor?
not only the steroids, they increase the risk.
Not known.
Not known,
It's
right?
not known. So the risk factors are what, like Dr. David said, the undescended testes, the germ cell, the kidney,
Germ cell infection, those are cannot be solved stuff like that. Risk factors.
no, so it was not a known risk factor. We may have some questions online, we will take them, but if you have any, okay, so this question from Dr. Yong, are you using different assays for AFP? We do them in male patients, and the consent also level we use in below the one. Okay, so that's a great question. So different labs have different assays, but that's fine. You can use your whatever assay that your lab uses, but even the one that we use at Parkway and your HDH, it was less than 8, you considered to be normal anyway. But if you find that there's something that is elevated above the normal range, please work it out. So it's very interesting that she asked it because recently I had a patient who went for a health screening, and the beta HCG was 8. And the GP who saw this was very, very sharp. And then she said, this is not right in a man, and quickly referred him on, and he was eventually. Yeah. So, it is, if you see any of these, if any of these things you are not sure, feel free to buzz us and we're happy to help anyone to answer any questions. Any answer, go ahead.
A young man who is sympathy attack. What is the cause? Is it the hypercoagulability or is it the emboli, tumor emboli?
Is a PE, the pulmonary embolism. Basically, whenever you have cancer, then there's.
The way is the source of the DVT.
Where's the source? Oh, he didn't have, why did he? I think probably there's also compression of the IMC, but he had disseminated malignancy, right? He has a germ cell.
Maybe the cause of embolism maybe from the tumor.
No, it's not. It's a pulmonary embolism. It's not a tumor emboli because we managed to recognize it and did a thrombectomy for it.
One last question is, what is the rate for frozen section, especially in young people?
So for us, it's actually the first stage is always to do a radical appendectomy, and no, we actually don't do a frozen section unless there is obvious signs of malignant spread. But even so, because we go through the minor approach, we actually push the testes out of the scrotum, which is original place, and actually will bring it up via the scrotum. So generally, if you are suspicious of any skin involvement, obviously this is a very advanced disease, and in this case, you might actually not want to do regular that's how front you might actually learn from chemotherapy and instances in these cases. Although they are rare, majority of the time, they should not have actually scrotum involvement, but this they can.
That case of hydroxyl, actually, if you press it, if it's hydroxyl, it's liquid. I mean, you can imagine the positive one.
That's what I'm saying. So it is, look, it is entirely possible that many times we don't know, or rather we think that it's actually just a very benign cause. But having said that, yes, I have seen hydrocele as big as a grapefruit or even fruit. And I've seen hernia that is a football size. I have no idea how to do so wrong. But it happens. And if you are not sure at the end of the day, you're not sure, do a quick ultrasound, everything's going to be reviewed. And we are living in Singapore. It's quite indefensible to say we don't make use of the resources that we have in the scan. So I think being ultrasound as well is quite safe. There's no radiation. I think it's quite reasonable in this case to actually do one examination.
So as a GP, let's say we due to pneumonitis, what is the left time before the pneumonitis occur?
Okay, so that's a great question. Pneumonitis can occur anytime from the start of pneumonitis. The most common is after the first and second cycle. So that is usually within the first 3 to 8
We
weeks.
as GP, we see them months away.
No, so exactly. So, but what may happen is some of these patients may present to you first with a cough or a fever. One is like in between the cycles, they may present to you. So if they, for example, tell you they are bleomycin or they are some form of chemotherapy, please always ask them the number of
No, when we do a check, let's say after 5 years, how we do the X-ray.
So these patients are
The classical picture that you go up.
yeah, so as you mentioned, these patients are also on chemotherapy, so fever can be neutropenic fever. So even if you give them 1% and back to the hematology, you want to give the neutropenic fever down on the liver as well. So I think the best thing is if you find that patient comes with a cough and it's unwell and you're not sure, just send the patient back to the oncologist. Right, so is at least we keep them on follow-up, and then we know that he's presented with cough, difficulty breathing, and then we can treat accordingly. Right, but
He means that it was in between chemo and
okay.
how long more?
Well, usually if you're finished, usually after the last chemo, we would have scan, but if that scan shows that no pneumonitis, the pneumonitis wouldn't come after you did it. Yeah, so you don't see pneumonitis sometimes after chemotherapy. Yeah, they'll come, you will know it. Yeah, if there's no further question, I will close the session, but please, sorry, take the question.
In the GP setting, young man, sometimes in the lung,
So I think the question is for the online audience is that the challenges of doing a quick examination in the GP and GP setting and not knowing what exactly it is. I think if it's a young boy, you're absolutely right. And that's why I say first principle for because if it feels about the same as the other side, always the benefit of being in a GP setting is that you don't have to diagnose anything at that time. Obviously, you can do a serial examination if you are not sure. Maybe ask them to come back a few weeks later to see. If there is suspicion and it doesn't feel about right, it's a left right side don't feel the same. Send it off for ultrasound. Like I said, for 15-year-old young boy, it's not an issue at all. It's a non-radiation imaging. It's quite straightforward and it doesn't cost a lot of money. And if you are concerned, especially in 15-year-old boy, something that you need to consider. Yes. Painful lung. So the painful lung you got to then depending on what your age group is about the same. If it's a young guy, less than 21 years old, anybody with a painful testis, the first thing you do is to draw the doctor. And in this case, I think it's quite straightforward. You will always refer to others news emergency or the urologist. So that is itself a very straightforward thing. Now, if you're talking about painful testis in a 30-year-old who's sexually active as a wife or sexually active, you won't be thinking about people, which is actually one of the most common causes. Now, if you're talking about a 50-year-old kind of a patient, and according to that, you could be looking at, in fact, a hydrocele. Hydrocele is there. So, depending on what is the patient profile, and the various things that actually come to mind will differ according to the age group as first principles. So I hope that answered the question. You got to get the pictures. Yes.
So you have a painless lung that tries to illuminate. Nowadays we still need to do a ultrasound. Or is it urgent or
the principle of transillumination, as you recall, is essentially only possible if you are talking about fluid hydrocele. It is very, very illuminating. It's quite nice to turn off the light. It's literally dusty. Well, I've done it in SGH to show medical students. Yes, and it's usually fluid, but if it's solid, it doesn't. And of course, the usual things that we learn in medical school, that you must be able to get above it, and that suggests usually still, if it's actually you can't get above it, you might actually be dealing with a hernia from the gastrointestinal as well. So, like I said, if you doubt something that patient has chronically have or is otherwise well from other symptoms like other symptoms, it's definitely something that you might want to be for.
If there's no further questions, I think I will close the session. Thank you so much for your attention. We have the QR codes on the table. Please scan and leave your feedback behind you. Otherwise, I will thank you so much for taking your time out on this Saturday afternoon to be here with us. Thank you very much. Ciao.